All this is Mubeen, Dr. Mubeen Sayed from drbeen.com. Welcome to one more show. Sorry, I got distracted right away because Luffy just started meowing as well. So we're going to have Luffy here as well, I think. Okay, so hopefully you had a great weekend. The discussion I wanted to do today is the CDC study. It is actually sponsored by CDC and I believe done by the teams from CDC. Study is actually good. I could compare this study in terms of data analysis as we've been looking at UK studies. Study is for data analysis for more than 800 hospitals for the patients, about, I believe, about 500,000 patients, for what kind of comorbidities do they have when they are hospitalized or in case they have died. Now, there is a bias, there is a possibility of bias, and that is that uh, they are looking at the patients who are in the hospital. So it is possible that there may be other reasons, but what they are contributing is to say those who are in the hospital or are in the ICU or have died, what are the top comorbidities in them? And I would go over some of their notes. They are thinking in some cases, for example, anxiety and fear disorder is one of the causes of, or one of the underlying conditions in people who are dying. And the authors think that it may be that the anxiety and fear disorders make a person less capable of protecting themselves, or maybe when somebody is in hospital or ICU, they are already anxious because of the situation, and then they get classified as patients of anxiety and fear. So, meaning it's not the final data, but it is an important observation for what kind of comorbidities or underlying conditions are observed in the most hospitalized patients and in the people who die. So let's look at this data together. So let's see. I'm going to just set up my with this full screen and OBS. I have to kind of think a little bit before I use the interface. So here is drbeen.com. Then here is the study. So if you look at this, 540,667 adults hospitalized with COVID-19, March 2020 to March 2021, 1 year long record of patients, and more than 500,000 people, adults, that they have seen. So I think it is a very good indicator, at least for us to understand who may have comorbidities, to understand that what are the high risk areas, and if there are things that we can do to keep things in control. For example, well controlled diabetes is actually a negative risk factor, meaning doesn't have much risk for the hospitalization, compared to uncontrolled diabetes, which is a positive risk factor. Again, I'm talking from this study. What that means is if somebody has diabetes, it is really important to keep the diabetes under control. So I'm just giving you some ideas for how this study and what kind of value it has. Okay, so let's continue for a couple of more references before we start looking at my illustrations. This is a tool that I also want to use. And before all of this, I want to give credit to John on Discord. These links are actually shared by John. So John, thank you very much. So here, British Heart Foundation, they have a beautiful tool, or a couple of tools. One, if you see here, this tool over here says access a QCOVID tool, and this, they have done a ranking system to say you input your age, your weight, your height, your comorbidities, and it would come back and kind of try to assess if we are at a risk of severe COVID or not. So I think it is a very important tool to have. And then they have another tool that shows in general, if we all, and it is disconnected with the server at this time, I'll reconnect it when we'll go over it. But if we all as a community are at a risk or not. So that's a beautiful link as well. So we'll look at that in a second. Let's go back to my illustrations, and I would give you an overview of the study. Then we'll do some parts of the reading. In the beginning, I'm just going to give you the summary, and then from there we will continue. So give me a second. Let me once again switch over to OBS and switch over to the screen. So here we are. So the question, if you are asking or you're thinking about anyone, am I at risk for severe COVID-19, or who is at risk for severe COVID-19? The objectives for the discussion today is, number one, we're going to look at that study that I just showed you. And number two, we're going to look at this tool for risk calculation. So study characteristics, I just talked about it as well. April 20 to March 1, 2020, almost a year, 540,000 people, age 18 plus. They were all hospitalized patients, 800 US hospitals, and they used the premier healthcare database. Just some study information. So let's start with the overall bigger picture. So the bigger picture is that if you see here, 94%, 94.9% of the patients who are hospitalized had at least one underlying condition. So even if they were young, they had diabetes or they had some other condition. So 94.9% patients out of these 540,447 patients that were hospitalized, 94.9% had at least one underlying condition. So this is important to keep in mind. And please, the second thing, it can be scary as well to say, okay, I have an underlying condition, and that means now I'm in trouble. No, there are underlying conditions that can actually be controlled as well and managed as well. So it's just a call for us to manage ourselves a little more aggressively, if not already doing it. Now, the second part, most common underlying conditions in hospitalized. So they have done three basic analyses: patients who are hospitalized, patients that went to invasive ventilation, mechanical ventilation, or patients who died. So they have analyzed all those three. Most common hospitalized, or the patients who were hospitalized, the most common underlying conditions they had, the top was obesity. Second top, essential hypertension. And the third top, dyslipidemias. And we'll go over these a little bit to see what kind of possibilities with these conditions is that make a person prone to severe disease. If you would like, we can go over these one by one in the coming days to explain why various comorbidities make us more at risk. Now, if you look at this part, this is the strongest risk factor for death. And the top was obesity, then anxiety and fear, then diabetes with complications. Please don't take away diabetes controlled. Diabetes controlled actually reduced the risk of death, meaning well-controlled diabetes made a person almost as normal as others, but uncontrolled diabetes is a problem. Now, a little more with the numbers. So as you saw that for the hospitalization, essential hypertension, dyslipidemias, obesity are top. So here, essential hypertension, 50.4% of the hospitalized patients had hypertension. 49.4% patients hospitalized had dyslipidemias. So almost half of the hospitalized population had dyslipidemias or essential hypertension. Dyslipidemias means cholesterol disorders, triglyceride disorders, fatty acid disorders, deposition of the cholesterols or fatty acids or other lipid related substances under the blood vessels, hardening of the blood vessels, coronary artery disease, and so on. And then obesity, 33%. Again, as we'll go over the study's weaknesses and strengths, the strength is, as you can see, it is a huge population that they looked at. That is the strength of the study. You can't go wrong at that big a level when you're observing the most common factors there. But at the same time, there could be a set of weakness. They have given 8 weaknesses of their own study. We look at them, and it could be that because we are only looking at the patients who are in the hospital, and then if they are diabetic, we'll say, aha, so this person is diabetic, that is why they may be here. But that may not be the reason. So we'll keep that in mind and continue. Then the strongest risk factors for death. The top risk factor for death is obesity. Adjusted risk ratio 1.30, confidence interval 1.27 to 1.33. So now this is something where one cannot say that somebody can just become or lose weight in 2 days or 3 days and say, okay, I'm fine. Just like you can start controlling diabetes very fast. But still, there are hormonal abnormalities that may be observed in people who are obese. So talking with the doctor, figuring out what may be the abnormal labs, and then trying to see how to manage them, in addition to doing walks or runs or whatever is easily doable without stressing out the body. If you stress out the body, let's say you really want to you want to lose weight very fast, and you are really doing rigorous exercises, that can actually cause a lot of norepinephrine release or stress hormone releases, which in turn can cause immune system, especially the NK cells of the innate arm, to be a little less active. So important to stay healthy, but also important to not put your body through a lots of stress. So talk with your doctor, get your labs done, understand what hormonal abnormalities may be there, understand what kind of levels of glucose and others are there. Normally insulin resistance is observed, and then see how to manage that all. So have a plan and work on it. So obesity is important. That was a top underlying condition in patients who died. Then the anxiety and fear related disorders. Adjusted risk ratio is 1.28, and then 1.25 to 1.31 is the range. And I'm going to read a little more. I'm just giving you a quick summary of this. If it is quick, we are about 13 minutes, 2 more minutes, and we'll be done with the summary. Then we'll do a deeper dive into various factors and read the paper itself. If you just wanted to see this much, you can leave after this. The calculators, the links are in the description. You can just go to the calculator, put your data in there, and see what kind of risk factor they think you may have. Strongest risk factor for death, one more, is diabetes, but with complications. Not just the diabetes with complications, uncontrolled diabetes, enough uncontrolled that there are complications. So 1.26, and then range 1.24 to 1.28. So top was obesity, second was anxiety and fear related disorders, third is the diabetes, uncontrolled. I'll keep saying it again and again. Then, this is another interesting thing, number of total complications. So as the complications increase, the number of complications increase. Somebody with one complication have a lower risk of, let's say, death compared to somebody with more than one complications. So the range was one condition, 1.53, and then 1.4 to 1.6 is the range for that. But look at these two numbers, 1.53 for one complication, and for 10 complications, 3.82. almost more than double. So as the number of complications increase, the risk for death due to COVID increases, and up to 10 complications increase the risk of death more than double compared to one complication. It's not compared to normal, it's compared to one complication. So that is also an important data point. So these are the high level summaries. Now I want to go over the study itself. So before we do a deeper dive in the study, maybe for the folks who are here, let me go over the link for the British Heart Foundation, so you can actually see how does that work, and then we will go in the study's depths as well. So give me a second. I'm going to now switch over. Okay, so here is the QCOVID tool. So this is a tool, if you see here, britishheartfoundation.org.uk. Let's see, QCOVID. What is QCOVID? QCOVID was developed by a team at the University of Oxford. The NHS has used QCOVID to understand who may be at an increased risk from COVID. QCOVID considers all your coronavirus risk factors together, including your age, the area where you live, and any underlying health conditions to calculate your absolute risk. Again, this is mostly for UK, but you would see that they have various countries in there as well. Okay, so what do the scores mean? As well as absolute risk, the total provides a risk rank out of 100. This is a way of describing your relative risk. So a score of 100 is most at risk compared to everyone else, while a risk rank of 1 would be the lowest risk compared to everyone else. It is important to remember that a lower risk rank doesn't mean no risk at all, just less when compared to other people with higher risk. So now let's look at the tool itself. And I'm going to use this tool for an arbitrary person. So let's say there is a person whose age is 50 years, male. Let's change it for us here, female. And I had put in Pakistani so you can see, let's say white British. Height, weight, UK postcode. I don't know some postcode, but you could put the postcode over here and it would actually look at the risk factors in that community and then use that as well for calculation. Beautiful. Nursing care or homelessness or some other meaning, not either of them. Diabetes, yes or no. Let's say we use type 2 diabetes. So now we are saying a 50 years old woman or young woman, female, of course, white British, 170 centimeters. So that should be 5 feet 7-8 inches, 73 pounds or 73 kilogram. Lives not in the nursing home or is not homeless. Type 2 diabetes. No chronic kidney disease, no sickle cell disease, no learning disabilities. So look, these mental disorders could be a reason that a patient cannot take care of them very well and may become accidentally, inadvertently, unwantedly exposed to the disease. Then cancer and its treatment, neurological problems, heart or circulation problems, other conditions, and then on the shielded patient list. So in UK, there are classifications of patients. So one classification is patients who are on the shielded list. They need to take more care of themselves. So I said no here. So let's calculate the risk. So here is the risk. Again, at the top of it, they have this disclaimer. This implementation of the QCOVID risk calculator is not intended for use, supporting, or information clinical decision making. So this is a informational or an alert system, you can say. So risk assessment, check this out. The table shows the absolute risk of catching and dying COVID-19 over a 90-day period based on the data from the first peak of the pandemic. There's a comparison with the risk for a person of the same age and sex, but no risk factor. So what they're doing is they're taking this data that we just input. They're comparing this data to someone of the same age and sex, but they don't have comorbidities. And they're going to see what is the comparative risk, absolute and relative both. So if you see here, and they've said here, the relative risk is the absolute risk divided by the average risk. So COVID associated death for this parameters that we put in. So this is a type 2 diabetes, not obese female 50 years of age or above. Absolute risk of catching and dying. Again, catching is not we can all catch it. The question is, if we catch it and then die, and this is within 90 days period, so absolute risk, for example, 1 in 6,579 out of 6,579 patients, if all of them with this risk parameters, they catch this disease, one of them will die. So the absolute risk is 0.0152%. Absolute risk with no risk factors. So another woman of this age and this height and this weight without any risk factors has the chance of 1 in 38,462. So you can see that here the risk has increased. So what is the increase? That is 5.8 times. That is the risk. So it is this number, A and B, they're divided. So that is the relative risk increase. Now, COVID associated hospital admission. So for the same woman, if she caught COVID, what are the chances for her to end up in a hospital compared to another person, same parameters, woman, this age, but without any comorbidities? So if you see here, this woman's chance is 1 in 1,044. So out of 1,044 patients of this parameter, one will end up in hospital. And then if you look at same parameters but no comorbidities, 1 in 2,695. So that is 2.58 times difference. So one can then put in our own numbers in there, and we can see what kind of risk is in there. Once again, this is not for clinical decision making. This is mostly for us to kind of be alerted. Now I want to see this one as well. This is actually an interesting number. Okay, so check this one out. You guys are so good with these things. Okay, so mortality impact of the COVID-19 emergency is 1.5. Apply the chosen mortality impact at different levels of infection. So mitigation 110, sex, male, age, let's say 30 to 35 years of age. Underlying conditions, let's say obese. And now, so this data is less. So I'm going to increase the age here just so that we can see the data. So if you see here, what they're saying is observed 1 year all-cause mortality in this age range, 56 to 60 males with the BMI greater than 40, or let's say obese. In this group, in last, so they have done the data analysis of between 1998 to 2017. This group, 1.11% is the chance of dying. So they say over here, we estimate there are 32,510 people in England with similar characteristics. Of these, we would expect approximately 361 to die each year before COVID-19 ever existed. Now, after COVID-19, with the selected assumptions regarding the COVID-19 emergency, we might expect there to be an additional 18 deaths amongst a group of people. So this is not an individual risk, but this is a risk that is at a group level for a certain parameter. So I think this is a beautiful calculator as well. So now, generally, we are done. We are done with the studies summary for CDC, and we are done with this tool. I'm going to go over the study's details. So if you are just interested in understanding what the study was saying, we've done that. Okay, so here's the detail. These parts I've already done. I'm going to scroll down to some of the interesting points that I had. And there are, of course, a lot. So, first of all, let's look at a more holistic list. So, essential hypertension. So, this is most frequent underlying medical condition in a sample of adult hospitalized with COVID-19. So, look at this. Hypertension is top, then lipid metabolism issues or dyslipidemias, obesity, diabetes with complications, heart disease, esophageal disorders, chronic kidney disease, anxiety and fear related disorders, bronchiectasis. Again, this is hospitalization. They're not talking about death here. Bronchiectasis, thyroid disorders, depressive disorders, implant device or graft related, sleep wake disorders, neurocognitive disorders, osteoarthritis, aplastic anemia, diabetes without complications, and then asthma. Now, I want to read this part. Diabetes without complication was associated with a 6% lower risk of death. So 0.95 instead of 94 instead of above 1. So 6% lower risk of death. 9% lower risk of invasive mechanical ventilation, controlled diabetes, and 2% lower risk of ICU admission. Essential hypertension was associated with an 8% lower risk of death, 6% lower risk of IMV, and a 1% lower risk of ICU admission. Asthma was associated with a 9% lower risk of death and a 4% lower risk of IMV. So they're talking about overall compared to other patients as well. The risk of ending up in a hospital or on IMV or death, these conditions actually reduce the risk. But once somebody is in the hospital, then, of course, as you can see, hypertension is one of the top found comorbidities. Then they talk about age stratified analysis. So they've done those analyses as well. There's a lot of good data here. Then here, the percentage, this is very interesting. I did not know this part. The percentage of the US adult population known to have 2 or more underlying medical conditions ranges from 38% to 64% by state. This is very important. What is curious for me is compared to other countries that may be doing better, for example, what does their data look like for one condition or two conditions or more? But in the US, if you take the minimum number here, you take all the US adults, and 38% at least have 2 underlying conditions. Then, and that is, you can see that there is a higher risk with that. Hypertension and disorders of lipid metabolism, the most prevalent conditions, and obesity and diabetes with complications, strong risk factor for death, invasive mechanical ventilation, and ICU admission are associated with well-described hormonal and inflammatory pathway abnormalities. I would add that. Meaning, if we are thinking that, hey, why is hypertension causing this? Or why is the lipid metabolism an issue? Or why is obesity an issue? The reason for that is that it is possible that there is an association of hormonal and other inflammatory pathway problems, which in turn give rise, one of their outcomes is the ones that we are seeing. Or, for example, in case of obesity can be caused because of hormonal abnormalities, and obese folks would get hormonal dysregulations as well. High baseline prevalence of obesity and diabetes combined with their association with severe COVID-19 illness suggests that these two conditions could have an outsized impact on the population. Just these two, obesity and diabetes. So obesity we cannot control right away, but diabetes we can. So that means, and they already are linked as well. Many folks who are obese are diabetic as well because of the insulin resistance. So that means important that as you are working to maintain and control your weight, control blood sugar levels as well. Although the authors have, and I would read it to you down below, authors have suggested that it is possible that we are looking at diabetes as a symptom of the disease itself, COVID. If somebody is hospitalized with COVID and they're being given steroids, they can actually develop temporary diabetes. Similarly, somebody who is under stress can develop temporary diabetes. Women who are, let's say, pregnant, they sometimes develop a temporary diabetes as well. So they talk about it down in the weaknesses of the study. It was found to be associated with a higher risk of COVID-19 illness only among patients aged 18 to 39, but with a lower risk of severe COVID illness among older patients. So they're talking about essential hypertension. This is very interesting. Essential hypertension in younger patients is associated more with the severe disease compared to essential hypertension in older patients. And I think you can connect the dots that if a young person has hypertension, then they may have, maybe they are young enough that they're not even controlling it well, plus they may have other issues as well. Plus, at that young age, when they develop dysregulations of hormonal or inflammatory pathways, that puts them at risk. So this finding supports a possible link with severe COVID-19 illness and identifies essential hypertension as a risk factor, especially among younger patients. Then, uncomplicated diabetes was found to be negatively associated with the risk of death and invasive mechanical ventilation. So, hospitalization, sure, but going on a ventilator or risk of death, uncomplicated diabetes actually was a negative risk factor instead of a positive risk factor. A positive association with risk of ICU admission was found only among patients aged 18 to 39 with uncomplicated diabetes. A previous study showed that although type 2 diabetes was a risk factor for mortality from severe COVID-19 illness, patients with diabetes and well controlled blood glucose had lower mortality than those with diabetes and poorly controlled blood glucose. Hypertension we can control, diabetes we can control. Weight loss cannot be fast, but we can start maintaining and then start losing. Anxiety and fear related disorders were a prevalent condition in our sample. They were also the second highest risk factor for death among the underlying conditions considered in our study. The reason for this finding, and please also realize that they had selected a bunch of conditions to look at. That could also create a bias, but these are the most prevalent conditions generally. The reason for this finding are likely multifactorial and may include a reduced ability to prevent. So look at this, somebody with anxiety and fear disorder. Reduced ability to prevent infection among patients with anxiety disorders. For example, if you say, hey, observe social distancing or physical distance or mask or other such protective measures, washing your hands, a person with these disorders may not be able to do it very well. And no fault of theirs, this is a disorder they have. And so they may not be able to protect themselves very well. In a subset of patients with pre-COVID encounters in our study, anxiety diagnosed before COVID-19 was not independently associated with death or IMV, mechanical ventilation, during COVID. And therefore, it is also plausible that anxiety was diagnosed during COVID-19 illness and may be a resulting sequela of COVID-19. So they're saying that if we saw people with anxiety, then we did not see any greater risk for hospitalization or mechanical ventilation. But when we look at people who are in the hospital, then we see this disorder. So they're saying maybe it is actually a result of COVID-19 as well. So that means some patients may actually not have the anxiety disorder, but getting COVID and ending up in a hospital made them anxious and gave them that, they ended up with that diagnosis. I can say that I'll become very anxious. If I get COVID and I end up in a hospital, I would almost think that now I'm going to die. So I will become anxious. So then they say future studies could explore the temporal and causal association between anxiety disorder and severe COVID-19 illness. There is a lot of more good data. I want to now very quickly, this is the last part, I want to discuss their weaknesses of the study that they think are there. So our study has limitations. What are those? So they have given about eight. First, the coding system that they're using to diagnose if somebody had COVID may be mistaken as well. Maybe some doctor may have mistakenly given that code or not given that code. But they say this is a smaller issue because the diagnosis sensitivity is high. Second, ICU risk estimate could be biased if ICU admission reflected factors other than severity of COVID-19, such as anticipation of future severity among healthcare professionals. So he's saying it is possible that somebody is getting into ICU or brought into ICU not because they had to be in the ICU, but the doctors thought this person is going to become severe, so let's bring them to ICU right away. Third, because the data were observational, we could not establish causal association. So this is a retrospective observation study, not a prospective study, so they cannot do that causal analysis. Fourth, relying on ICD-10-CM codes to identify underlying medical conditions may have underestimated their prevalence. For example, obesity was diagnosed in 33% of the patients, which is possibly an underestimate of this condition given the national prevalence of 42.4%. So there may be some incorrect measurements. Fifth, prior literature shows evidence of both increased documentation and underdiagnosis of certain chronic conditions among patients with more severe illness. So other literature shows that sometimes chronic diseases are more documented for COVID, sometimes they are ignored for COVID. So there may be some level of missed information or added information or more rigorously looked at information. Sixth, the interrelationship of the condition made it difficult to obtain the independent association, which could explain why certain conditions, disorder of lipid metabolism, sleep-wake disorder, esophageal disorders, and so on, had a positive association with COVID-19 illness when not adjusted for other conditions as negative associations. So one more data analysis issue. Continuing, seventh, we were unable to access the association of current treatment modalities for medication. So they can't say what the patients were seeing and what is the result of that. Finally, including only the most frequent underlying medical conditions in the estimation of the risk could have caused us to miss less prevalent risk factors. So this is what they have. At the end of the day, what they're saying is among patients younger than 40, essential hypertension was also a risk factor for death. The total number of underlying medical conditions was a strong risk factor for severe COVID-19 illness. Total number, 1 or 2 or 3 or 4 or 5. So as the number increases, the severity's chances increase. Preventing COVID-19 in populations with these conditions and multiple conditions should remain a public health priority, along with targeted mitigation efforts and ensuring high uptake of vaccine when available in these people and their close contacts. So this is the discussion for today. There are a couple of things in here that we can follow up with maybe in the coming days. One of that is there is a study which is published in American Heart Association, I believe, their journal, that talks about the usage of uh, angiotensin receptor blockers and reduction in possible death from COVID. Remember, we had done one study analysis about 6, 7 months ago where they had said, we don't know enough, we don't have enough data, so don't change anything. There is a study that actually shows that people with hypertension and then a specific category of antihypertensive may have benefited. So if you would like, we can talk about that. Or if you like, I have discussed obesity, hypertension, asthma in the past. I have not discussed the fear and anxiety disorders. So if you like, I can look at these top um, conditions once more. So these are the two things. Thank you very much for your time and listening in. Let me go back to my. So please do me a favor, like, subscribe, and share. If you don't want to do anything, then just hit like, don't even subscribe. So that would help as well. So like, subscribe, and share. And if you like to support this work, there are links in the description. You can buy me a coffee, or you can become a Patreon patron, or you can use PayPal to support this work. Thank you very much, and I would see you in a few minutes again.